Thank you all for coming to Webinar Wednesday. I'm Carly Endries. I am the Outreach Coordinator for the North Dakota Brain Injury Network. Welcome to Webinar Wednesday. We have a good lineup all through December, so these will go on every other Wednesday through December, and they'll continue after that as well, but what's scheduled right now is through December. CEUs are available. After this is all done and put onto our website, there'll be a CEU request page that you can fill out, and just give me a day or two to get that back to you for a formal certificate. If you know of anybody that would want to speak at upcoming Webinar Wednesdays, or if you have a topic request or anything like that, please feel free to reach out to me and let me know. All my info can be found on ndbin.org. Most of you guys probably know Rebecca Quinn, but she is our director and considered the expert on brain injury in North Dakota. I say that, but it's true, so I'm going to say it as much as I can. But yes, so today we're going to talk about an important topic, and one that we do get a lot of questions on about aging and brain injury and kind of differentiating all of that. So I'll let you take it over.
Yeah, great. Thank you. So welcome. Yes, so this was actually, I had done this presentation for the Plains Conference on Aging and had gotten some really good feedback on it. So thought that it would be something that would be good for doing for our Webinar Wednesday. So specifically around brain injury in older adults. One of the things going to review, so if I were to say like objectives, going to review one, the incidence and prevalence of brain injury amongst the older adult population. Older adult is one of the higher incidences of brain injury. So that's kind of our first objective. And then going to review the impact of aging on a brain injury. So once somebody's sustained a brain injury, what is that impact as they get older in age? And then review some of the research around brain injury and other neurodegenerative diseases. So I always start off with talking about what is a brain injury, just really quickly. I tend to just use the vague term brain injury. That does include any insult to the brain after birth, leading up to your more progressive of dementias. So sometimes we do think of a traumatic brain injury, and that is those that occur from an external force. But brain injury can be other types of acquired brain injury. So it would include anoxia, which is oxygen deprivation, infectious disease. I'll be really tracking and interested on how those who have potential brain injuries from COVID down the line in the future. Chemical or substance exposure, so that might be somebody that's had an exposure to like carbon monoxide. Or a stroke or a tumor, so that as well. One of the things is both of these mechanisms of injury can result in chronic disability, so whether it be external force or internal, and can get worse and are impacted by the aging process. So definitely important to talk about both of them. However, sometimes more research has been being done around specifically TBI. So where it is specific to just TBI, I do mention that, but mostly it applies to all brain injury. Some of the facts and figures, this is just really quick if you've heard me present before, but TBI specifically in the US, an estimated 2.8 million people a year. Of those, 50,000 of them will die. We'll have 282,000 hospitalized, and then, but nearly 90%, 2.5 million, are just treated and released from the emergency department. One of the things that really has changed with brain injury over the years is definitely more individuals are surviving with brain injury. So when we talk about that aging with a brain injury, that'll come into play because it's kind of a new population. One of the things, and this is data from the CDC regarding TBI specifically. So this is really looking at the rates by age group. So when I previously had talked about that, 2.8 million, this is those, but broken out by age group. The number one category, and the category that I think gets all the press and publicity, is your 15 to 24-year-olds. So you can definitely see the spike there, the purple line being total and the blue being emergency department visits. So definitely the highest amongst that 15 to 24-year-olds. However, the next significant category, the second highest category, is your over 65. And some of the things to make note of amongst that over 65 on this graphic is the orange line is your hospitalization and the green is deaths. So you can see that the total and emergency department visits are high amongst the younger category, and then the second is the over 65. But as you can see from the orange line, the hospitalizations and the death, that for those over 65, there is a much higher increased rate of those that are hospitalized or die from their head injury versus, it just being an emergency department visit. So that's important to look at is that it is more significant in individuals having that hospitalization. One of the things, so despite this high incidence, older adults may be less likely to seek medical attention and are also less likely to be accurately identified, even when medical attention is sought. So even though it is, the second highest population category, it's not one that's readily recognized. I don't think when you talk to people about TBI, as I said, a lot of press and publicity and whatnot, and all of just kind of our awareness, understanding really goes to that more younger category, specifically our student athletes, those pieces. But people don't tend to think of that older adult category. So some of, again, more facts and figures. But more than 80,000 ER visits are for those 65 and older. As I said, they do have the highest rate of hospitalization and death, so much higher than the other population. This looks at the leading causes of brain injury. So again, this is traumatic brain injury info from the CDC. And it's kind of an interesting graphic. But you can see definitely in your 0 to 4 category, falls, which is the red line, is pretty significantly high. Our children falls. There was just a newspaper article about a child in Minnesota falling from a second floor. So falls are a high category amongst that 0 to 4 category. And then when you get up into, school age, then struck by against, which struck by against is usually your sports industry injuries there. And motor vehicle crashes come into play, and assaults. So in those mid ranges from school age through young adulthood, you kind of have all of the causes converging. But you can see once we get to over the age of 44, so after, that kind of middle age, falls again starts to have quite a significant uptick, and the others kind of fall off. And then definitely over the age of 65, falls is a predominant cause of brain injury and does stay there. Interestingly, though, kind of interesting to me, the struck by against, so the green line does have that uptick right at that 75 plus area. And a lot of that actually is really related to traffic pedestrian. And so it's said that over the age of 75 is more at risk of being struck by a car as a pedestrian than under the age of 5. So you have more risk of being struck by a car as an older adult than you do as a young. But we always make sure that we watch children, but we're not necessarily thinking of older adults. So that is really that green little uptick there at the end. So that's looking at our causes. One of the things that is on the rise, and this graphic is from the CDC because the CDC was sort of alarmed by it, deaths from falls related to TBI are on the rise. So this is a graphic looking at from 2008 through 2017, and deaths from falls overall are on the rise, but most notably amongst those over the age of 75, and those living in rural counties. So here in North Dakota, we have a large older adult population, and we are predominantly rural. So that is one of the things that the CDC is really looking at, and looking at things that are affecting that, like blood thinners, more frequent use of blood thinners, those pieces that are really affecting that, falls in older adults leading to death. So that's something to kind of be on the lookout for. So the question is, why is this a hidden epidemic? When we talk about, and it's almost a hidden epidemic within a hidden epidemic. We say that brain injury in and of itself is a hidden epidemic, but then its impact on the older adult population is a hidden epidemic within that. It's very rarely talked about within even the brain injury community, how much, there's a lot of information and resources and those pieces out there about children and sports industry injuries and return to play and kind of academic supports, and a lot of information around working with that population, but there really isn't amongst the older adult. And so it is this hidden epidemic within a hidden epidemic. One of the pieces is often the injury is overlooked. That's the case in general with brain injury, but even so with older adult brain injury. I think that either one, it's seen as no big deal, particularly some, generational pieces there. Our current older adult population very much generationally likes to play down things, it's a struggle across getting them to seek any type of medical care, not just brain injury medical care. So kind of see it as not a big deal, not really following up on it. Or often more acute issues overshadow it. So a lot of times, an individual may have a fall that leads to a broken hip, but because the broken hip is really seen as the big orthopedic issue that needs to be dealt with, the head injury from the fall is not really, noticed at the time. It's not, identified. And so it kind of one of those, and that often overlooked. Often the symptoms can be seen as part of the normal decline or aging behaviors. So, in the example of, somebody having a fall and a broken hip, at the time of the fall, the head injury may not be identified. Instead, the broken hip is the focus. And then if 2 to 3 weeks later, they're having some, memory issues, some confusion, things like that, it's seen as, well, that, that's to be expected after a broken hip, that, is part of this aging process. And really, it's not appropriately identified that, no, this is part of, a change from having a brain injury. Again, that lack of awareness, really seeing that TBIs or concussions are really only are only for the young, are, not something that you would expect in older population. And then another piece is brain injury is different amongst older adults, particularly traumatic brain injury. You can have a more severe injury from a less impact. So individuals can have a more severe injury from a same level fall. That, if I were to do a same level fall, it, most likely would not cause a brain injury, amongst, a younger population, but on an older population, it can lead to a brain injury. So there's some of these are risk factors. So this is according to a doctor that spoke on trauma in the elderly. One of the risk factors is low force leading to substantial injury. So as I just said, it takes lower force to cause an injury amongst the older adult population. In elderly falls, 50% of those that have a traumatic injury are at high risk for repeats. So, but often that's not identified as a risk and not mediated. Again, as I said, adults age 65 and older are at greater risk of being hit by a car as a pedestrian than children. Many older adults can't navigate crossing the street or a crosswalk. So some of these are risk factors that are involved. More risk factors, particularly these are risk factors around sustaining a brain injury. You know, as we age, tend to have lower body weakness, more vitamin D deficiency, some medications, particularly those that cause dizziness or cognitive impairment, such as tranquilizers, sedatives, antidepressants, blood pressure medication, and then I identified blood thinners as a piece. They are a risk factor in that they can cause either the individual to have that dizziness or them to be more susceptible to bleeding in those pieces. Vision problems, you know, making us more susceptible to falls, foot problems, foot pain, leading to having more walking impairment, less ability to kind of navigate, and having a higher risk for falls. So those are kind of the risk factors for sustaining a brain injury. And then these are some of the aging risk factors that really impact the outcome of a brain injury, are impacting kind of whether or not a force or a blow causes an injury. So one is having a pre-existing medical condition. You know, as we age and older adults tend to have more other conditions going on. So anytime somebody has other conditions, it's a complicated recovery and can make it more difficult for them to recover and have a more complicated outcome from the brain injury. A decrease in neurochemicals. As we age, we have a decrease in our neurochemical production. That is part of why, you know, there are things like difficulty with sleep and, you know, some of the other difficulties that individuals have as aging. Part of that is related to that decreased neurochemicals. Well, we really rely on our neurochemicals for our brain recovery, and having that decrease really can impact outcome. Having less cognitive reserves. So if you are in your late 60s and you have a brain injury, you have less cognitive reserves to pull from to help you with your rehabilitation from that, to help you manage any type of, like, you know, putting towards rehabilitation or manage any type of like accommodation as you're dealing. So that kind of having that less reserves. Deficits are more pronounced as a result when individuals are, you know, dealing with a brain injury. So they tend to be more pronounced and more kind of difficult for individuals to accommodate. And then another piece is atrophy to the brain makes an individual more vulnerable to sustaining a brain injury and more vulnerable to the outcome. So one of the things that happens with the aging process is that we do have structural changes in the brain related to age atrophy. So these are CT scans on for individual to, you know, comparing a 27-year-old brain versus an 87-year-old brain. And so you can just see that on the 27-year-old brain, the brain takes up more space in the skull. So it takes up more space, it has more, you know, matter there. Versus the 87-year-old brain has had that atrophy where it has slowly started to have a decrease in mass, a decrease in you know, cellular structure. And one of the things is, as part of that atrophy, is that as that happens, you have more space within the skull. So that being part of why a smaller, a lower level fall or a less severe fall can cause a more severe injury, is because you have more space in the skull for the brain to be moving around. And you have more, being part of that whole cognitive reserve piece, you have more actual cellular matter for somebody when they are working on recovery. And so less cellular matter at play to pull from as part of their brain injury recovery, meaning that any injury to the brain mass that they do have will have a larger impact on that individual. So another thing that age atrophy really impacts is that a subdural hematoma. So a subdural hematoma is what happens when you have blood pooling between the brain and the dura mater. Why it's called a subdural, because it's between your brain and then the dura mater, which is kind of an outer covering. It's kind of like the sac that the brain's in within the skull. So you have your brain, and then you have, you guys can't see my hand, you have your brain, and then you have the dura mater sac, and then you have the skull. And so when there's blood pooling between the brain and the dura mater, that's called a subdural hematoma. And so, but one of the things that happens with aging and when you have brain atrophy is that the tiny veins that are feeding between that dura mater and the brain are already stretched, because as the brain is atrophied and pulled away, those veins have already had to stretch and be pulled. And so as a result, they're more easily injured when you have a blur to the head, and you have a higher incidence of subdural hematoma within the elderly. So there is this higher incidence of subdural hematoma. But one thing, because of that atrophy, you have more space. In a younger brain, what happens is if somebody has a subdural hematoma, as that blood pools, it starts pushing on the brain. And that's when you start noticing some, pretty significant symptoms pretty quickly after the initial head injury. So that being related to things like an individual developing the stuff that we typically tell people to look for as a sign that a head injury is worsening. So somebody developing vomiting, they have, unequal pupil dilation, somebody, being excessively sleepy, unable to rouse them, slurred speech. So those are kind of some of those signs, and that being caused by that subdural hematoma starting to grow and press on the brain. When you have an older adult and they have that atrophy, what is happening is there's more of a gap. So they're more at risk of the subdural hematoma because those veins are already stretched, but they're also at more risk of it not being recognized because there's more gap for the blood to pool. And so what can happen is it may go unnoticed, and you can have what's called chronic subdural hematoma, where somebody kind of either has a slow little bit of bleed in their brain that's happening, or they've had it happen and then the veins heal up, but they now have this pooled area in there. So that is why it is important to check out. So again, why am I telling you this? Because the negative impact as that goes on can, not be readily apparent right away. Brain injury looks different in the older adult population. And so sometimes having to seek care when maybe you wouldn't think about it. If you had somebody in their 30s, do a fall, you maybe wouldn't seek care as far as a head injury, but with an older adult, it's more important to follow up because of this sort of risk factor, and particularly from the atrophy of the brain. So really important for it to be checked out. Here are some clues suggesting brain injury within the older adult population, but particularly looking for things that maybe would be a sign that after somebody's had a brain injury, there is maybe a chronic subdural hematoma going on or something that needs to be checked out. So, having that low-grade headache that won't go away afterwards, typically a headache after sustaining a concussion or something should go away in, 1 to 2 days. If it doesn't, then that really would be something they would need to have checked out. Having more trouble usually, than remembering, utilizing their, cognitive skills, any type of blurred vision, or even somebody just complaining that their eyes tire easily. So, not being able to, maybe if they've done the crossword in the past or they've watched TV, their eyes tiring and it becoming more difficult for them. Loss of sense of taste or smell, although right now with COVID, that's kind of a difficult one, but definitely loss of sense of taste or smell as a sign, any changes in sensory. Ringing in the ears, changes in any sexual drive, any slowness in thinking, speaking, acting, or reading. getting lost or easily confused. A lot of these, as you can see, do overlap with some of the things that you would see with kind of typical aging. You know, feeling tired all the time, lack of energy, change in sleep pattern, sleeping longer, you know, more than normal, loss of balance, any mood changes. And like I said, these do overlap with what we would expect from like a typical brain injury. I mean, a typical like older adult. However, these are things that you would look for as like a change. So has there been a, you know, kind of sudden change to sleep pattern where somebody is now sleeping much more than they did before? Really wanting to figure out what is going on there as far as why is there that sudden change, and then asking, you know, was there a head injury? Or if you know there has been a head injury, looking for these type of things. Brain injury outcomes. So compared to younger adults with TBI, older adults on average, and I will say older adults, you know, it's all on average, they do undergo more in-hospital procedures after a brain injury. So usually including imaging and neurosurgery, that being definitely related to that risk of subdural hematoma, and then that, you know, that if they have a subdural hematoma. So because of that risk, usually any neuroimaging is more recommended within the older adult population. You know, it is now not recommended to do any type of neuroimaging within the pediatric or the young adult, or even like, you know, early adulthood population after just a mild head injury, because it's usually not significant. But amongst the older adult population, they do recommend, you know, more imaging because of that risk of, and then having to, you know, if somebody does have a subdural hematoma, it having to be addressed. So that piece, individuals have longer acute care hospital and rehabilitation stays after a head injury, and then are more likely to require continued medical care. So they definitely have, you know, more likely to require ongoing medical care from either their primary provider or, you know, worse, being like discharged to a nursing home. Have a slower rate of improvement on functional measures, worse functional outcomes and greater level of disability, and then have a higher rate of discharge to nursing home. So definitely having that impact of the injury. The injury has a more significant impact on an older adult. So the older you are when you sustain a brain injury, the more of an impact it's going to have on you. One study looked at, and they estimated that for every 10 years of age, there's a 40 to 50% increase in the odds of a poor outcome after a brain injury. So if somebody is, you know, 50, then they maybe would have a, you know, 50% increase in having a worse outcome than a 40-year-old. A 60-year-old would have a worse outcome than a 50-year-old. So as you get older, continually having that worse outcome. So looking at some of the cognitive outcomes. So older adults are at risk for poor cognitive outcomes following TBI. We talked about that. It's possible that the cognitive impairment is predisposed to the injury and that there's some decrease in cognitive reserve presence. So that's one of those things that we talked about, was an individual's cognitive functioning being a risk factor to them even sustaining a brain injury. So if somebody was having some cognitive decline, that may have led to them having a fall because they were, you know, less able to, you know, be watching for any falling hazards, or less able to keep up with things. So that possible cognitive impairment already in place at the time of the brain injury. And then having that decreased cognitive reserve presence. So how much cognitive reserve somebody has will really come into play in their ability to be accessing rehab, their ability to really overcome some of the cognitive impairments from the brain injury. And then the effects of medication needing to be carefully considered, particularly any type of medication that's causing any type of cognitive impairment in addition. So medications that maybe cause neurofatigue or causing dizziness, causing those pieces would really also be impacting how much that individual cognitive reserve on board and their ability to kind of overcome a brain injury. So functional outcome, really, again, looking at this, this is looking at the TBI model systems. So one of the things I did like about this is that it was really looking at a study that looked at something that was a little bit more positive because some of the data was pretty negative. The TBI model systems data is a large, huge database of individuals sustaining brain injury that is longitudinal and goes back, I think, 28 years. And so the TBI model systems do different research on it. So this was a research study that looked at individuals over 65 who had received acute inpatient rehabilitation. And they did find that majority of them did achieve significant functional improvement. So there was functional improvement. It was the inpatient rehabilitation was beneficial. There was that functional improvement. 2/3 of them were discharged to a community setting. So I think that's important because, you know, before it said on average, there is a higher incidence of older adults after brain injury being discharged to a nursing home versus your younger population. But when the model systems looked at it, 2/3 of them were discharged to a community setting, so still a positive there. And then after nearly a year later, 85% of them were in a community-based setting. So even though there's some of the information out there kind of sounds doom and gloom and negative, it is still, there are still positive outcomes after, you know, with older adults in brain injury. So moving to next is looking at, but what about, so that kind of wraps up, you know, older adults sustaining a brain injury when they are an older adult. But one of the things that is definitely, we get asked a lot of questions about, and it's on a lot of people's minds, is, but what about past brain injuries? What does it mean to age with that history of brain injury? One of the things is, as I said, this is a relatively new area of research because really, particularly those with more severe or moderate brain injuries, it really is a new developing population. It is rare for me and my role to meet somebody that has survived a severe brain injury from 30 to 40 years ago. I mean, I'm now meeting more of them because we really are coming up on that cusp of when more and more individuals were surviving. But really having a severe brain injury, you know, 40 years ago was much more of a death sentence than it is now. And so I think that this is something that we, like I said, are on that cusp of more and more of those severe and longer term brain injuries surviving. And will be something that on moving forward, we'll have many more individuals that have survived those brain injuries. And one of the things that I can say is true anecdotally for the individuals I work with, and the research does back it up, for some, it definitely does appear that brain injury may accelerate the aging process. It's unclear exactly how that happens or why that happens, but it does. I just yesterday was talking with a woman who had a severe brain injury 18 years ago, and was talking with her about the fact that now that she's moving into her 50s, may start to, you know, be experiencing some more cognitive problems and may be dealing with that. Even though she, for the past 18 years, has managed her brain injury pretty well, she now is going to be moving into a new area of aging with that brain injury. So there are some issues that can arise, specifically for those that have more severe brain injuries. Any medication that somebody is on for a brain injury, if they've been on that medication for long term, can be hard on the liver and the kidneys over time. and would definitely need to be monitored and adjusted. So even if somebody has been on a pretty good medication management, their need to kind of monitor and adjust that as appropriate can be ongoing. This is very true with anybody that's had a chronic condition, but is something that has to be on the lookout as somebody ages with brain injury. Any type of orthopedic problems. So if somebody has had any orthopedic effects from their injury, whether it be, single side weakness or misuse or a dropped foot, any of those type of orthopedic problems, those over time can become exacerbated. So as an individual, if an individual has a dropped foot that has caused a limp, and they maybe went through some significant PT for that 15 years ago, they now might have to deal with some of the side effects of 15 years of kind of misuse and how their body has remedied that. So they may then have some, alternate hip degeneration from the kind of having to accommodate for it. So those type of things can cause that wear and tear that somebody may need. As somebody with a brain injury has kind of, as they age, they may need some more in different PT to work with them on this, may need more orthopedic interventions to assist and help them learn kind of new accommodation strategies as that kind of aging rehab. Long-term caregivers. So definitely, anytime, something that we deal with, particularly adult children whose parents are their caregivers. As they age, really that parent caregiver or even that spousal caregiver is aging in and of themselves. So when you have an individual that is providing direct care as a family member, and they then maybe are dealing with their own things, and particularly if somebody's been providing direct caregiving for quite a while, they can then have their own, orthopedic and stress problems related to like back issues and those pieces. So that kind of as part of that caregiving piece. And then the next piece is really looking at this idea of the compounding effect. So, and that's how I always explain it to people, is the compounding effect that you can have a brain injury and you can be aging, but doing both of them at the same time isn't necessarily the most beneficial. So, and this is a quote, conceptually, and making the assumption that the brain has finite capacity for recovery and adaptation, and that both TBI recovery and aging utilize the same plasticity mechanisms, a brain after TBI may have fewer resources to devote to the aging process. And so that's something I definitely explain a lot to people, and is part of where the aging process catching up with individuals with brain injury earlier. This is something that we see often and have calls about, and the people that we work with. In my experience, it does seem to be about a 5 to 10 year kind of earlier. So if somebody has had a severe brain injury, or not even any brain injury, but they've had some and they've been successfully managing that injury. So successfully managing any memory impairments, any cognitive loss, any of that from that injury. And then they all of a sudden get to their mid-50s. And there's a normal process that for somebody that's never had an injury before, when they get to their mid-50s, they maybe start to have some of the on the horizon aging cognitive issues to start to manage, or any type of symptomology of that normal aging process. But if you've never had a brain injury, when you start to have kind of some of the subtle memory impairments, some of the subtle like tip of the tongue word finding issues, things like that, that start to come as part of the normal aging process, when you're in your mid-50s, you have the resources and the capacity to manage and accommodate that. But if you've had a brain injury and you already are using your resources and your capacity to accommodate whatever symptomology you have from the brain injury, to then throw the curveball of, oh, now you need to manage the aging as well, you don't have the same reserves and resources to do that. So it tends to kind of catch up sooner. So somebody might all of a sudden in mid 50s be having those tip of the tongue word issues, and they've always had them from their brain injury, but now they've gotten worse because now they're dealing with the aging component as well. Or maybe they've never dealt with problems of like word finding before, but because they have dealt with problems of like attention and concentration, and their reserves are going to attention concentration, they can't put those cognitive reserves to the helping remediate the word finding. So it's sort of that compound effect. And that is definitely one of the things that, you know, I found in working with people that is really difficult, particularly for individuals that have had recovery from a significant injury. So they've learned to manage it. They've gotten all of their accommodations and their resources and all of that in place. And then it's almost like, oh, wait a minute, this is shifting ground. And then the question comes into play of, is this their brain injury or is this something else? And it can be very difficult for individuals that have managed their brain injury enough to return to work, you know, manage family life, those type of pieces, to really have that aging component catch up with them sooner than they kind of anticipated it. So I'm kind of dwelling on that a bit, but I do find that that's one that I think it's almost important to really start working with individuals of brain injury to start a conceptual understanding of, and an understanding of that may be on the horizon. Because it, like I said, it really kind of, for a lot of individuals I've worked with, it comes out of the blue. They sort of saw their brain injury as stagnant and were like, whoa, wait, what do you mean? So I do think that it's kind of, you know, that like warning them about, you know, what's on the horizon. So along with that is this idea that in brain injury, there really has been a lot of focus on the moment of the injury and kind of that immediate after effects rehabilitation. But there hasn't been that much understanding and concept of brain injury as a chronic condition. And I think part of this has to do with even our conceptual understanding and our phrasing of it as a brain injury. You know, an injury is something that's a moment in time. It happened, it's done, you're healed from it. You know, I broke my arm, I had an arm injury, my injury is all better now. And that's kind of the way we think about brain injury. Particularly people that go to rehab, and we see it as they completed rehab and they're done. But again, this is out of the model systems cohort. And this was really looking at those that had, you know, received inpatient rehabilitation and their reduced life expectancy. And the idea of brain injury is a chronic condition. So this is something that in the brain injury world, there really has been more this movement towards the idea that brain injury is not just a moment in time, but it is a chronic condition. Once you've had a brain injury, it really changes your neurochemical processes, your neurochemical structural makeup, and as a result, causes you to have ongoing chronic condition things that need to be dealt with and managed moving forward. And they did do, as part of the study, really looked at life expectancy. And they found that individuals with brain injury had a lower life expectancy than individuals that had not sustained a brain injury. Now, I will say this is those that had received inpatient rehabilitation from specialized brain injury. So we're not talking about concussions here. This is definitely those that have sustained at least a moderate, if not mostly severe brain injury. But they found that they were 2.23 times likely to die than those of comparable age, sex, and race in the general population. So they found, your likelihood of death is higher after you've had a brain injury. They estimated that the reduced life expectancy was about 9 years. So that, if somebody has sustained a severe brain injury, and they maybe, all things considered, would have lived to be 90, after a brain injury, they would expect that they would only live to be about 81. So that was sort of their guesstimation of that reduced life expectancy. They did find that individuals with brain injury were at higher risk of dying from seizure, although that is a relatively small cause of death. They did find that the external causes of death really had more to do with managing the symptomology from the brain injury. So falls, accidental poisoning, homicide, motor vehicle accident, suicide. So a lot of these really looking at things that are not related to an aging process, but are related to the management of the brain injury and how much that brain injury has affected them. The increased fall risk, how much have they, has their unsteady gait, their cognitive problems from brain injury, those type of things made them more susceptible. Accidental poisoning. Individuals with brain injury are at higher risk of things like overdose, whether it be accidental, just from medication or from like an intentional, illicit use of medication, those type of things. So motor vehicle accident, how much has that individual's cognitive and their reaction time and those pieces come into play regarding their ability to, drive, and how much is that at risk. So those type of things. So that's definitely, that life expectancy being shortened is an impact for individuals with brain injury. So again, that compounding effect comes into play with that, and this is from researchers in the UK that really looked at, and they found that for individuals living with brain injury are chronologically 4.6 years older than a control group with no history of brain injury. So, which I said about 5 to 10 was my gut, which that kind of falls in line with this. So they estimated that. So, for somebody with a brain injury, this is saying that if they're 50, they maybe would be chronologically presenting more like somebody that was 55. So if they're 60, more like somebody that's 65. The accelerated trajectory of brain atrophy we observed is in keeping with progression of neurodegenerative process triggered by the injury. The effects of age and injury are likely to act synergistically, leading to deficits in information processing and other neuropsychological measures known to be impaired in normal aging. So they use the word synergistically. I tend to use compounding effect, but I think, it's just even that understanding, that idea that as you've already had impairments in that area, how much it then impacts normal aging. So, which does bring us to something that I think we get asked about a lot as well, the neurodegenerative diseases in brain injury. How much is there an impact and an overlap between brain injury and neurodegenerative diseases? And that's one of those things. So looking at this, a neurodegenerative disease is a heterogeneous group of disorders that are characterized by the progressive degeneration of the structure and function of the central nervous system or peripheral nervous system. So basically that's saying they are a group of diseases that are, different in their own way, that are progressive in their degeneration of an impact on the nervous system. So basically, the biggest thing with neurodegenerative is they're progressive and they're impacting the nervous system. How much those overlap with brain injury is still up in the air, very much. Some of the cognitive things that some of the common neurodegenerative diseases are your dementias, so including Alzheimer's disease, Parkinson's disease, ALS, and CTE. So those are kind of common neurodegenerative diseases. I'm going to kind of walk through a few of those and talk about what studies and research says about them. So one of the things, and this is from the Journal of Neurotrauma, TBI is now well-established risk factor for neurodegenerative diseases of aging, including Alzheimer's and Parkinson's disease, but mechanisms are poorly understood. And that basically, that sentence in and of itself pretty much sums it up. Yes, we know that they are a risk factor, but the mechanism of how that happens and why it happens and how much of a risk factor is still very much up in the air. So one of the key things, particularly when I've looked at the research that makes it really difficult, is just even TBI and dementia risk. One of the things is, a key point is, what is the definition of dementia? That's really hard, because medically, the definition of dementia is kind of a general term that means any like cognitive impairment that impacts an individual. So that was me saying off the top of my head. So dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that is severe enough to interfere with daily life. That's what a dementia is. So you can have a dementia caused by TBI, but that is not saying that TBI is causing a progressive dementia, which is the difference there. So if I am 25 years old and I am in a car accident, and after 6 months after that car accident, I have a memory impairment and cognitive, problems from that brain injury, I would be diagnosed with a dementia caused by my brain injury. That is not the same thing as a progressive dementia that is getting worse as I'm aging. So the reason why I make that clear is because a lot of times the research is very kind of unclear as to what they're talking about, and particularly media studies and all of that. So really making that distinction between progressive, regular dementia versus progressive dementia. So I'm going to give you an example of that, and hang on just a second. So this was a Swedish study that looked at, this is a Swedish study that got a lot of press and publicity, front page of like everything and and really talked about the risk of dementia, a dementia diagnosis after brain injury. And the Swedish study found that TBI is a risk factor to developing dementia. But in looking at the study, it said they did not make a distinction to were they talking about progressive dementia, or were they talking about just dementia? So it seemed, because how they did the study was they compared medical records of those that had a diagnosis of brain injury and those that had a diagnosis of dementia. And they found that there was an increased risk of having a diagnosis of dementia if you had a diagnosis of brain injury. However, that kind of makes sense, because if we go back to the definition of dementia, it's having any type of cognitive impairment that interferes with your daily life, which you would kind of expect to happen after a brain injury if somebody, is having ongoing symptomology. So, and one of the things that really stood out to me was, particularly during your first year after sustaining the brain injury, the rate was 4 to 6 times higher that you would get that diagnosis of dementia. So to me, I'm like, okay, so during the first year after a brain injury, somebody is 4 to 6 times more likely to get a diagnosis of dementia than somebody that doesn't sustain a brain injury. Well, that kind of just makes sense to me. And that says to me that they're being diagnosed with dementia caused by the brain injury, not a progressive dementia. They also found in 15-year follow-up that there was an 80% risk of, during that 15 years, of having a dementia diagnosis. Well, again, that doesn't speak to it being progressive dementia, because I could sustain a brain injury and at that time of the injury not get the diagnosis, but 5 years later, if I've lost my job, if I did that, then I might get that dementia diagnosis. Still doesn't mean that it's progressive. But again, this was a study, came out in 2018, got a lot of press and publicity. Everybody really latched onto it. Look at, TBI and your risk of developing dementia. But really, again, as I said, it wasn't clear. They're not talking about progressive dementia. So when I read the study, I'm kind of like, okay, but I can't tell what was diagnosis from their brain injury versus what is a diagnosis of a progressive dementia. So I really raised that point because I think it's important to consider that. And when we are talking about the whole, even memory impairment from brain injury, what is your causality with the neurodegenerative disorders versus what is that overlap between a brain injury and aging process? Because one of the biggest, factors for developing, a neurodegenerative disorder is aging. The older you get, the more likely you are to develop one. Well, if we already know that individuals with brain injury are chronologically younger than their counterparts, then it would make sense that you're going to have, neurodegenerative disorders developing earlier within that population, but it not necessarily be related to an increased risk, it being part of that brain injury as a chronic condition piece, and that, they're just more susceptible to the aging process as part of that. So specifically around Alzheimer's, there is evidence that does point to the fact that after a TBI, Alzheimer's may occur earlier than without a TBI, particularly in individuals that were predisposed to Alzheimer's. So if somebody is predisposed to Alzheimer's, particularly genetically, that individual would develop it younger than they may have. Again, that's back to that whole chronic condition and, the chronological age versus their TBI age piece. There does seem to be a synergistic effect, so that kind of compounding effect between the TBI and the allele protein E4, which is really part of that genetic factor related to Alzheimer's disease and dementia, that really does create that compounded effect. So particularly for individuals that have sustained a brain injury and are genetically predisposed to Alzheimer's, it is an increased risk factor. So if you're genetically predisposed to Alzheimer's, you already have one risk against you. But then if you have a brain injury on top of that, you are that much more likely to develop Alzheimer's. Obviously, other factors to consider are TBI severity. So, if somebody's had a moderate to severe brain injury, that is going to have more of an impact on that impact of chronological age and how much that injury is affecting their, chronic functionality and ongoing, and their own individual age. So, as I said, age is the biggest factor within neurodegenerative diseases and developing them. So, as somebody ages, the more likely they are that they would develop that, even if as part of their brain injury. So looking at TBI and Parkinson's disease, research results have been somewhat inconsistent. I say somewhat inconsistent. There are some studies out there that show a fairly clear link between Parkinson's disease and brain injury. But then there are actually a number of studies that show no connection whatsoever. So although there is enough to say, yes, there's some link there, there's enough out there to say it's inconsistent and really not clear what that is. The mechanisms for how brain injury might be impacting Parkinson's disease is unclear. And it's definitely not a direct causation. So saying that the head or brain injury actually causes the Parkinson's or any of that. This was something that definitely after Muhammad Ali developed Parkinson's, there was this idea that you know, his boxing and his history with that had led to that. However, you know, there's no direct causation. There's no way of knowing would he have developed Parkinson's without ever having been a boxer. So it's not enough to establish that, yes, there is that link. There is some thought around possible mechanisms. Particularly one is that the brain injury uncovers any underlying Parkinson's disease. You know, Parkinson's being more affecting your peripheral nervous system, and so individuals being more at risk for falls, you know, car accidents, and more at risk of sustaining a brain injury as they maybe are in their early stages of Parkinson's and haven't quite, you know, haven't gotten a diagnosis yet. So the Parkinson's may actually be a precursor to the brain injury in those cases. So they're not really sure. And in that is it sometimes the individual sustaining that brain injury that actually uncovers, oh, these are the factors that led to it. So making it more of a risk. And the other piece is that somehow the brain injury affects the dopamine producing portions of the cells. So as part of that, Parkinson's really is related to dopamine and dopamine production in the brain and how much dopamine there is as a neurochemical. And so they're not sure if is it possible that when individuals had a brain injury, it lowers their dopamine production and that then causing inflammation or some of those tiny tears, bleeds within the brain that cause scars and are part of that kind of cascade to development of Parkinson's. So those are kind of some of the mechanisms that they're sort of exploring now that they're not sure of how much Parkinson's is really kind of affecting that. There was, and this kind of brings in the ALS as well, there was a study done in Finland that investigated the association between TBI and neurodegenerative diseases. And it did find that a history of moderate to severe TBI had an 80% increased probability of future neurodegenerative disease compared to persons with a history of mild TBI. So even in this, they were comparing the history of moderate to mild, found that really there was that 80% increased with having that developing a neurodegenerative disease. They did find that again, that development was a dose response based on TBI severity. So you would be more likely to develop one, you know, a neurodegenerative disease if you had a more severe brain injury versus a mild. They did find that TBI was associated with increased risk for dementia, but not for Parkinson's disease or ALS. So this actually was a study that, again, looked at dementia, that, as I said, you know, if we're looking at that as broad, any neurocognitive impairment kind of is really tough to make that direct connection. But it did find that not for Parkinson's disease and ALS. And I will say, other than that, the research around ALS is even more inconsistent than the research around Parkinson's. There has been a few ALS cases that have had a past history of brain injury, but ALS is in and of itself a pretty rare condition. And if brain injury was a risk factor or any type of causality in developing ALS, they would anticipate and expect for there to be a higher incidence of ALS given the high incidence of brain injury. So they think that yes, there may have been those few anecdotal cases, but at this point, there's not really that direct connection with ALS, and they're still doing ongoing research, but not clear at this point. So the next neurodegenerative condition, chronic traumatic encephalopathy, CTE. This is what the movie Concussion is about. So for those of you that want to know more about it or want to watch a movie, the movie Concussion was really about the discovering of CTE. You know, CTE as a condition has been around for quite a while. It used to be called dementia pugilistica. So, and was really thought of as punch drunk. It was first described in, 1928. I will say in the 30s, there was information out of the football league about, chronic, kind of what they call chronic, head problems. So it kind of has been around for a while, but nobody had really understood it. There wasn't an understanding of how it is as a mechanism. So then really when CTE was discovered, there was looking at, it was actually the pathologist that was doing research and work for the NFL really started to realize that there was this high incidence of a protein in the brains of athletes that he was observing. And really was looking at specific athletes, but since then it's been looked at across all the different athletes, different sports, and really has seen within military personnel, specifically as well, having this protein. So one of the things with CTE is it is a progressive neurodegenerative disorder. The progression of CTE is slower than other neurodegenerative diseases like Alzheimer's or frontotemporal dementia. One of the things that CTE, it does not include beta amyloid deposits, which are the deposits that develop in Alzheimer's. Instead, it has this tau protein deposits. So it's a very similar production of or similar process of having deposits that are like gumming up the works in the brains, but it's just a different protein that's gumming them up. One of the things is then with CTE is those deposits are much more localized. They tend to be more in the frontal lobe and really in that sense are affecting things more like cognitive functioning, but like higher executive functioning, like planning, follow through, those type of functioning, but also really affects mood and behavioral management, self-esteem, self-awareness, those pieces that are really important in the frontal lobe. So whereas in Alzheimer's disease, really those proteins, the amyloid deposits, tend to be more diffuse throughout the brain and are not, not quite so localized. So I have only worked with a couple of individuals that have developed CTE because it really is seen within those that have mild, multiple mild brain injuries. So they don't see CTE, that development of the tau proteins, in individuals that have like a single brain injury, even severe and moderate brain injuries. It really is seen in those that have had multiple mild injuries, and they feel that it's more related to that neurocascade process and that tau protein being released when damage is done on the cellular level, but it takes the buildup of enough of that protein to really develop CTE, and so that is required, that repetitive mild head trauma. So one of the things that is important to remember is that individuals with neurodegenerative diseases do not usually have a history of TBI. So there's not a causal effect or even enough of a real correlation effect to say, you know, individuals with neurodegenerative diseases have a history of brain injury. And that survivors of brain injury do not invariably acquire a neurodegenerative disease later in life. So there's also not enough, you know, high enough incidence of neurodegenerative disease within those individuals with brain injury, and particularly once you factor in considering brain injury as that chronic condition and overlapping brain injury as a chronic condition with the aging process, how, you know, kind of filtering that out from the development of that separate in and of itself neurodegenerative disease. So it's, you know, important to kind of make that, you know, that remember that, because I feel a lot of times when people look at some of the research and the flashy headlines and things, they have that idea that anybody that's had a brain injury is susceptible to development of a neurodegenerative disease. And that's really not exactly what the research says. So what can we do? This is kind of my wrap up area of why telling you all of this. I will say, as far as the neurodegenerative diseases and that, I welcome anybody to read lots of research on it. I have, but it is very much going down a rabbit hole. You know, it could be lots and lots, but what do we do about this idea that brain injury overlapping with the older adult population? Definitely, I would say screening and focusing on primary prevention and secondary prevention. Screening, you know, one, being on the lookout for later in life brain injuries. So just being aware, particularly if there are different programming that works with older adults, you know, whether it be home health, senior services, any of that, really being on the lookout in that idea that there may be individuals in that population sustaining brain injuries. And if they, you know, if they've had a blow to the head, if they've had a fall, if they've had those things, then really being aware that that makes them more, you know, vulnerable and needing to follow up on that, you know, getting them that medical attention, getting them that care. But also, it's recommended that programs that serve older adults be screening for a history of brain injury because of this chronic effect. And as we now have aging brain injuries, really be on the lookout for how an individual with brain injury is aging and knowing that history about that individual. That being able to have an understanding of, yes, this individual has had a brain injury, to be on the lookout for, like I said, that compounding effect. It may then affect their normal aging process. And if you're a provider or you're an individual working with them, having that idea of, oh, this is what I could expect, but needing to have that understanding of what that history and screening for brain injury. So if you ever want to adopt a screening for brain injury and you are a provider, feel free to reach out to us. We'd be more than happy to help you with that. Primary prevention, obviously, again, any, you know, family members, you yourself, if you're an older adult, anybody you work with, doing primary prevention to be preventing brain injury, addressing the risk for falls, addressing any cognitive decline, increasing safety awareness, beefing up cognitive reserves, doing all those things to really prevent a brain injury from happening, particularly since we know it's the, you know, second highest category of individuals sustaining brain injury. And there's not that much prevention put towards it. So really wanting to, you know, look out for those things. Secondary prevention, you know, one of the things that we know and was identified earlier, once an older adult has sustained a brain injury, they are 50% more likely to sustain a second one. So when they have had that brain injury, identifying the injury when it's occurred, doing that follow-up, looking for that kind of possible chronic subdural hematoma, providing that appropriate care, management of any comorbidities, particularly if there are things like dizziness or blood pressure, or those pieces that led to their brain injury to begin with, like maybe a fall, really making sure that those are managed, regulating their medication. Providing ongoing education to that individual, so helping that individual have an understanding of what it means, how this has impacted them, really following any return to activity guidelines provided to them. You know, individual older adults may be more sensitive to return to activity guidelines like returning to driving and things like that, but needing to follow those for their own safety. And that's just so, and beyond that, you know, you can contact us. So that's it. Hopefully that provided a really quick overview. I don't know if there are any questions. You guys are welcome to utilize the chat or just ask us if you would like. Are there any?
Karen says, good job as always. Thank you.
Oh, thank you.
Josie says, thank you. No questions? You must have been so thorough.
No questions. I must have been so thorough. I will tell you, it's going down a rabbit hole looking at the research around the neurodegenerative dementias and really trying to figure that out. And I'm a social worker. That is my area. I am not a, you know, I am not a researcher. I am not particularly not like a biological medical researcher, but reading them. But one of the things that surprised me was a lot of the research is coming from people at that high level, that particularly like that, what is normal aging and the normal process of an individual with brain injury versus what is, you know, a new condition. And in some ways, reading some of the articles, I could tell that they haven't had anybody that has any like real world experience involved in them. I'm like, you guys need more like normal people on your like research committees. Because it is unclear. But I will give an example. I one time worked with an individual who was 20 plus years post brain injury. He had an injury, but had been doing okay with it. Everything was fine. I mean, I wouldn't say okay with it. He had support services, all of that. But his provider, he was getting some home health services. His home health provider reached out because he all of a sudden was having some aggressive behavior, argumentative, refusing to help with his ADLs, unwillingness to, you know, allow his providers in to help him with like bathing, things like that. And they reached out to a psychologist. And the psychologist gave them the answer of, oh, well, he's had a brain injury. That's typical in somebody that's had a brain injury. So they then reached out to me and wanted to know how to manage his brain injury. But I looked at it and I was like, well, wait a minute. Why is this seen as needing to manage his brain injury? Because to me, this is new stuff. Like if he's had a sudden change in his behavior, a sudden change in his willingness to work with providers, his, you know, ability to complete his ADLs, that to me is not all of a sudden his 20-year-old brain injury changing. That's something new coming about as part of his aging process. And so really, I then provided that pushback to the provider and said, no, wait a minute, let's get in. really got him assessed for depression, which whether he had a brain injury or not, being assessed for depression, still an impact and a factor, but really getting him in to work with a provider on the fact that he was having some progressive decline and those pieces. So I think it is important to consider it all together and how all those pieces fit together. Okay, well, thank you guys. Any other questions? I'm more than happy to answer them. As you know, we're always here to provide information and to help out any way we can. Thank you. Carly, I don't know, what is our next topic?
Our next one, oh, you put me on the spot here. Christabel Braden. So she is a very inspirational survivor that I think you'll all enjoy hearing from her. So
yeah, Christabel will be coming up. So in 2 weeks. So thank you, everybody. We appreciate it.